Welcome to another edition of the WITS January Upscale Workshops. My name is Sharda Kalanidhi. I'm Technical Director of the WITS Datathon. This January, we're launching a datathon on Kaggle, and our topic is triple-negative breast cancer. We are so fortunate to have one of the world's experts on breast cancer with us. Dr. Kurian is Professor of Medicine, Epidemiology, and Population Health at Stanford University School of Medicine. She's Associate Chief of the Division of Oncology, co-leader of the Population Sciences Program at Stanford Cancer Institute, and Director of the Women's Cancer Genetics Program. Dr. Kurian graduated from Stanford, attended Harvard Medical School, followed by internal medicine residency at Massachusetts General Hospital, and completed oncology fellowship and a master's degree in epidemiology at Stanford. Dr. Kurian's research focuses on the identification of women with elevated breast risk and on the development and evaluation of techniques for early cancer detection and risk reduction. As an oncologist and epidemiologist, she aims to understand cancer burden and improve treatment quality at the population level. Dr. Kurian, it is a real pleasure and honor to welcome you to our workshop. We would love for you to share your perspectives on breast cancer.
Well, thank you so much for having me. It's really a privilege, and I'm excited to be here and have the opportunity to speak with you. I'm going to share my screen. Hopefully that's visible to everybody at this point. Yeah? Good. All right. Well, then I will proceed. And again, just really thrilled to be here and learn more about what you all do. And I'm thrilled to have the opportunity to introduce this problem to such a smart group, and glad you're going to be thinking about it. So I will talk about breast cancer and the challenges of metastatic disease in particular. See if I can advance. Very good. So I want to start with a bit of national and global context for this disease so that we're all on the same page. This slide shows the causes of death in the United States, and they would look similar in most developing countries if you saw a figure like this. So what we can see here is looking on the y-axis, the rate per 100,000 in the United States population, and then on the x-axis, time. And it's interesting to see causes of death here. We see that diseases of the heart, so coronary artery disease, heart attacks, have been common for a long time, but they're actually coming down, which is really a triumph of cardiovascular medicine and screening. We see that malignant neoplasms remain high, maybe coming down a little, not a huge amount. And then you see the other things on the list here. But what I think is interesting is that really, as of now, we're seeing cancer being perhaps the leading cause of death, if not one of them. And in some particular ethnic groups, it already is the leading cause of death. This is a very common disease. 1 in 3 to 1 in 2 Americans will develop cancer in their lifetime. And we see similar trends in other developed and developing countries. So none of us will go through life without knowing somebody who has to deal with this. Breast cancer in particular is an important tracer condition. This is the most common cancer of United States women. As women, we have an average lifetime risk of 1 in 8, or 12.5%, of developing this disease. It's an interesting disease for epidemiologists like myself to think about. The incidence has risen, but the mortality has fallen, which is good, since the 1970s. And these successes are due to a combination of things. One of them being that early detection, finding it when it's small through mammography screening of the population. And this is basically an X-ray of the breast that we start in the United States, usually at age 40, sometimes later or earlier, but usually at 40, is effective at finding it earlier. And when we find it earlier, we have good treatments of various kinds. So surgery and then medical treatments that I'll describe that are effective at curing the cancer in many, but not all cases. This is a disease for which there are very well-defined genetic, reproductive, and environmental causes, so we know a lot about it. And I'll also talk a bit about the way it is a lens through which we can understand and aim to address health disparities as well. So I just want to show you some world maps that I think are instructive when we think about breast cancer. This is from a few years ago from the World Health Organization, but honestly, it wouldn't look very different today from 2018. So here we see the age-standardized rate of developing breast cancer. Light color means a low rate per 100,000. Dark color means a high rate. just eyeballing this, we can see, all right, breast cancer is a disease of westernized developed populations, right? We see North America, we see Western Europe, we see Australia, we see some parts of South America that really are the most common. And then we see kind of intermediate rates in parts of the rest of Eurasia here, parts of South America. So you kind of get a picture of what the demographics of this might be, right? Now let's look at mortality rates. So we see a different kind of picture here. Here what we see, the light color means the mortality rate is low. The dark color means that it's high. So as you would think, we do have some mortality rate in the countries where the incidence rate is high, but not the highest. Unfortunately, the highest mortality rates are in places where, as we know, there are going to be less access to the kind of resources that we need to treat this disease effectively. We see sub-Saharan Africa, right? We see parts of South and Southeast Asia. We see parts of South America. So again, there's a bit of a disconnect here, and it makes clear that resources are important and is one of the things to keep in mind as we talk about this disease. So let's talk a little bit about what influences breast cancer outcomes and mortality at the population level and the individual level. This is a really nice study by our colleague at Stanford, Sylvia Pavritis, who is a wonderful data scientist herself and has been a great mentor and colleague to me for more than 20 years. I have the greatest respect for her. We can see here a study that she did where she was using a simulation model of breast cancer to try to understand national trends. And so the blue line here, this light blue line, is really what actually happened from 1975 to 2011. What happened with breast cancer mortality? It went down for most people. That's good. Everything else here is a simulation of what would have happened under different conditions. If we had not made any of the advances in early detection through mammogram screening or treatment that I'm going to tell you about, since the incidence rate has gone up, the mortality rate would also have gone up like this if we hadn't gotten better at managing the disease. But since we did, we estimate that screening is responsible for making it go down to this orange line and treatment down to this gray line, where the two of them together are what got us from here to here. So again, I think striking, and I think makes it clear that both are important to reduce mortality, and that if you want to do well for people, you really should be thinking about doing both things. So let's talk a bit about risk factors, subtypes, and staging, which will be important for you to understand breast cancer. Just a bit about risk factors. It's a busy slide. We don't have to go through them all, but I told you that 1 in 8 women in the US get breast cancer. It's not random. Some women are more at risk than others, and there are a few well-described risk factors that go along with being more likely. So here I have them organized by descending degree of relative risk. So really high risk factors, things that quadruple your risk of getting breast cancer over the average. Age, like almost all cancers, risk of breast cancer increases with age, probably as we accumulate more mutations over time. Having a strong personal or family history. So if you've already had breast cancer once, particularly at an early age, you're very likely to get it again. If you have a strong family history, more than 2 first-degree relatives, like a mother and a sister, your risk is high. And that often is because it is a sign of carrying a high-risk gene mutation, which are rare, but not vanishingly rare, and confer high risks when they are there. There are 2 of importance named BRCA1 and BRCA2. Sometimes we also see findings on mammogram will cause a biopsy, and then we do a biopsy and we see some tissue findings called carcinoma in situ, ductal carcinoma in situ, or DCIS, lobular carcinoma in situ, or LCIS, that are not cancer yet, but we call them stage 0 cancer. They look like cancer under a microscope. They can't yet invade outside their confining basement membrane in the tissue, but leave them alone and they might, is sort of how you might think about it. Going down to the next category of sort of moderate risk factors, they tend to be things like having maybe only 1 affected first-degree relative. And that sometimes goes along with another kind of gene mutation that isn't as strong as BRCA1 and 2, CHEK2 or ATM. Sometimes you can have exposures. People who got treated early in life with radiation to the chest for diseases like lymphoma. We see a lot of those at Stanford because we're a site of expertise for that. Those people subsequently have a very high risk of breast cancer because of the high radiation exposure to the chest. Sometimes we see something called extremely dense breasts on mammogram, which just means that there's a lot of white colored tissue and the mammogram is hard to read. That's associated with risk. So are high postmenopausal estrogen levels. Then I think about things that increase risk only a little bit, but are common. So things that make a dent in the population, though not so much in an individual person. Early menarche or first period before the age of 12, or late menopause after 55 years. Late age at first pregnancy, I'd sort of a joke, since so many of us do have pregnancies after 30 these days. When we say late, I certainly did. But then as we look at some of these other factors, moderately dense breast tissue on mammogram, no pregnancies or breastfeeding, recent use of hormone replacement therapy or oral contraceptives, postmenopausal obesity, interestingly, is a risk factor. There are some other lesions you might find on a breast biopsy that are increased risk a little bit. Some other exposures, alcohol consumption is a risk factor, more than 1 or 2 drinks per day. Interestingly, greater height is a risk factor, as is higher socioeconomic status. That kind of goes with those global maps I showed you, right? This is a disease of prosperity in some ways, of obesity, of earlier menarche, of all of those kinds of things. And we think that's sort of what's going along with that picture. So let's get into breast cancer subtypes, because I heard you saying triple negative breast cancer, and let's describe what that means. So breast cancer is not all the same. It's not one size fits all. This is a rather busy picture, but for data scientist types, you may like that because it's cool looking stuff. And it is gene expression profiling, so tumor microarrays of gene expression profiling. These are famous studies that actually were started at Stanford years ago, and more work was then done at the University of North Carolina with Charles Peru and Lisa Carey, looking at breast cancer, published in JAMA in 2006. What they did is they looked at different breast tumors and they looked at gene expression and tried to see if clusters of distinct gene expression fell out. And here on this plot, low gene expression is green, high gene expression is red, and we're really just looking for patterns that cluster together. So here in this purple group, there was a pattern that they observed, and they called it luminal A. And what they found that was quite interesting was that it mapped very well to some of the standard tumor markers that we measure in the clinic. Those 3 important markers that we always measure are estrogen receptor and progesterone receptor, which are basically receptors for the 2 main female hormones, and the reason why a lot of these hormonal exposures can cause breast cancer because of raising those levels. The third one is called HER2. HER2 is an aggressiveness factor. It's basically a growth factor gene, which is sometimes overexpressed on breast cancer. And so these 3 permutations of those 3 receptors are how we classify breast cancer. So they found that this most common type, luminal A, mapped to something called ER and or PR positive, HER2 negative breast cancer. They found another one called luminal B, which was all 3 positive or triple positive, ER and PR and HER2 positive. They found one that they called HER2 enriched that expressed HER2, but not the hormone receptors. And then they found the one that we'll be talking about quite a bit, which was called basal-like and found to be negative for all 3 of these. ER not expressed, PR not expressed, HER2 not expressed, triple negative. So this really began to tell us there are separate kinds of breast cancer and they behave differently. What was learned was that luminal A, or ER/PR positive and HER2 negative, do by far the best. Triple negative, by far the worst. And here is just a pie chart of what this looks like. If you look at distribution in the country, about 73% of breast cancer is the good kind, hormone receptor positive. HR positive here means ER and or PR positive. Hormone receptor positive and HER2 negative, that's the best kind. 12% is triple negative, okay? It's less common, but it's bad. And then the HER2 positive kinds together, HR negative, HER2 positive, and HR positive, HER2 positive, make up the other 15%. So that gives you a sense of what we're dealing with. Now I want to talk about staging. We talked about the biology, the subtypes. Now we're going to talk about the anatomy, how much cancer is in the body. So this is an image of a woman's breast and the lymph nodes that drain the breast. Every solid tumor like this will have a lymph node system that drains it. So if you look at colon cancer, if you look at lung cancer, prostate cancer, they all have a lymph node system. And that's where cancer tends to go first if it's going to spread, is to what we call the regional lymph nodes. For the breast, the first stop is the axillary lymph nodes. If it's going to spread more, it might go to more distant lymph nodes like supraclavicular or other nodes. But so when we look at this, we stage cancer in terms of how big it is and how far it's gotten from where it started. So as I mentioned, stage 0, that carcinoma in situ, it cannot invade beyond the breast, almost never kills anybody, okay? Stage 1 means that it is only in the breast so far, and it's small, it's less than 2 centimeters in size, but it is already having the potential to invade outside of where it started. Stage 2 happens when it gets bigger, so it's gotten to greater than 2 centimeters, or when it's spread into these axillary armpit lymph nodes. So you can be in stage 2 if you have 3 or fewer lymph nodes involved. Stage 3 means you have a big tumor, breast tumor greater than 5 centimeters, and or you have more axillary lymph nodes involved, 4 or more, or it's begun to spread over to the other lymph nodes, the supraclavicular, or it's begun to get into the skin to do something we call inflammatory. All of this is bad, but it's still curable. So here you sort of have to imagine a line between stages 0 to 3 and stage 4. Right now, we can cure anything above the line. We don't cure stage 3 nearly as well as we cure stage 0 or stage 1, but it's still curable. As of now, when you cross that line to stage 4, this is not a curable disease. That is true for nearly every other solid tumor, meaning not a leukemia or blood cancer. That's true for nearly every other solid tumor there is. I invite you all as smart data people to think about that. That's a problem that needs to be solved. So why do we care about staging? Here you have a sense. 10-year relative survival by stage. Okay, stage 0, everybody lives. Stage 4, unfortunately, people don't do well. This was 2006. The numbers look a little better now, but it does make it clear that you'd much rather be up here than down here. So let's talk about early stage disease, which again is the better one to have and where we try to find this disease when we can. I'm going to show you some care pathways, and these are a little busy. I won't go through them all, but just so you have a sense of what happens to someone. I told you that women get screened, so they get yearly x-rays of the breast, mammogram, usually starting at 40. Maybe someone sees something on the mammogram and says, you know, we need to do a needle biopsy. We need to sample this, and maybe that needle biopsy comes back as cancer. The most common thing is you go to a surgeon who will cut away the tumor, either just by doing an incision to remove the tumor itself or by doing a mastectomy, and we can talk about that. If the tumor is aggressive, like triple negative, you probably will need some chemotherapy afterward, some relatively harsh IV medication that we can talk about, of which the goal is to get rid of any lurking cancer cells. And sometimes that also targets that HER2 gene. You may also need radiation therapy to the breast to keep the cancer from coming back there. If it is an ER-positive tumor, you might need some medication to block estrogen receptors. Eventually, all of this is going to end, and then you are in a state where we say you have no evidence of cancer anymore, but we're going to watch you to make sure it doesn't come back as a distant metastasis somewhere else. That's the most common path. There are variations on the theme. Sometimes if it's one of those ER-positive, HER2-negative cancers, you might not need chemotherapy. Maybe you can just get the anti-hormonal therapy and support. Maybe you're needing radiation therapy because you had a smaller surgery, and then you can go down that path. This is a more complex path where if you have a really big tumor, you might need chemotherapy first to shrink it down to make it possible to do surgery, and then you might go on one of these other paths. So I won't get into that a lot, but just so you understand what this looks like. Let's talk a little bit about treatments. When we're talking about early breast cancer, you have to do two things. One thing you have to do is remove the breast tumor where it started. You need to get it out of the breast and lymph nodes, and that's done with surgery. There are two kinds of surgery. One is called a modified radical mastectomy. That's where they remove the breast, but they leave the chest wall muscles. Sometimes you'll hear people talk about a radical mastectomy. That was years ago when they also thought they needed to take all the chest wall muscle, which was very debilitating for women. We now know we don't have to, and that's why it's called a modified radical mastectomy. A lumpectomy is when you make a much smaller cut. You just take out the tumor plus a surrounding rim of normal tissue. Trials now that have more than 20 years of follow-up have shown that you can do either of these and get the same survival, which is great. However, to make this lumpectomy safe so that the cancer doesn't just grow right back, you have to follow it with radiation therapy to the chest wall and lymph node area for almost all lumpectomy cases. Only rarely do you need that after a mastectomy. But so pretty much every woman with breast cancer will get some kind of locoregional therapy, surgery plus minus radiation. So that takes care of the breast cancer where it started. Is that enough? The answer is no, okay? Why is that not enough? Often the surgeon will do it and they'll come in and they'll say, great news, we got it all. We cut it out, there's a tumor and then there's a rim of normal tissue, there's nothing else, we're all done. Why do we have to give medication? I'll talk more about this, but the reason why is that we know that if we don't give any medication, unfortunately, some women, even though it looks like we got it all, 5 years, 10 years down the road will show up with that same breast cancer having metastasized somewhere else. And we know this is because even when we don't see it on our imaging scans or the tissue we cut out, there are some little cancer cells in many cases that have probably escaped into the bloodstream and are hiding out. And unless we kill them now, while there are not very many of them, they will come back and grow and make trouble. So that is why medication or systemic therapy. When we do this, we try to leverage all the molecular targets available to us. So if that cancer cell has estrogen and progesterone receptors, we're going to use something to block them. I think of them like a catcher's mitt on the cell. We're going to use a drug that stops that catcher's mitt from being able to be turned on by our own estrogen in the body. We use drugs with names like aromatase inhibitors or tamoxifen. With that HER2 aggressiveness factor, we're going to use antibodies, so something that fits like a lock and key to block stimulation of the cancer cell. They have names like trastuzumab and pertuzumab. They're awful gobbledygook names, but these are important drugs that save a lot of lives by blocking that pathway. And we always try to match the intensity of our therapy to the risk level. So if you're doing an anti-hormonal therapy, if it's an early stage tumor, maybe you can do only one drug like tamoxifen. If it's a stage 3 cancer, maybe you need multiple different kinds of drugs. And sometimes, like I said, in some cases, you might even give chemotherapy first and see how well it shrinks away, whether it's all gone at surgery, to decide whether you need to give more drugs after that. And sometimes we'll use gene expression tests to see if the cancer even needs chemotherapy. So that's another thing we do, but that is the upshot there. So let's talk about metastasis. I want to just give you a sense of kind of what it looks like for a patient's care when she develops metastatic disease. This is a very nice presentation by my colleague, Jennifer Caswell-Ginn, where she was mapping out kind of what it looks like. So let's say we had a woman here who is 55, diagnosed with maybe stage 1 or 2 ER positive, not involving the nodes, HER2 negative breast cancer, let's say in the year of 2010. Maybe she's just getting one of those anti-hormonal therapies for maintenance, no evidence of cancer on her scans or anything. But then unfortunately in 2013, maybe what we see is she has pain in her hip and we do an x-ray and it turns out there's a lesion there that we biopsy. And lo and behold, it is breast cancer that has metastasized to her hip bone. When that happens, that's stage 4, that's metastatic disease. Unfortunately, we cannot cure it as of 2024. Unfortunately, what that means is we then have to treat her continuously with various therapies. And so usually you start with one drug. This is just an example, fulvestrant. Often you'll get a long response. She'll be on it continuously every 3 weeks. And for a long time, it makes the tumor shrink and stay under control. But probably after somewhere like a year and a half or so, it will stop working. The cancer will get resistant and you have to switch to another drug and then another and another. And what we're showing here is that 90% of patients are feeling well enough and doing well enough to get a first drug. Only 68% are still feeling well enough or still alive to get a second drug. 51% to get a third and 25% to get a fourth. And ultimately people do die because the cancer just multiplies and kills them, unfortunately. This, unfortunately, is the same story for nearly every solid tumor you can name, okay? Colon, prostate, lung, breast, etc. Most patients are treated continuously until their death. Most of them live less than 5 years with metastatic disease. Why is there this cure barrier for metastasis? Whoever figures that out will win the Nobel Prize and should. And so this is the major barrier that is the problem for cancer right now. So let's talk about metastasis. What happens with breast cancer metastasis? What does one of these cells have to do to make this occur? This is from a nice review article from recently, and they made the point that for this to happen, here's the primary tumor in the breast. Cells have to be able to sneak out beyond the breast, get out of there, and start to invade locally. And then they have to be able to get into the lymph nodes, like I mentioned. Once they get into the lymph nodes, they have to be able to do something called intravasation, which just means getting into the blood vessel so they can travel in the blood, kind of like a train, right, to other destinations. And that is where you would see a metastatic tumor cell potentially riding this blood highway elsewhere. And then a tumor cell has to be able to do extravasation, get out of the blood vessel and get into the tissue. So here, this person had a tumor cell that somehow got out into the brain, set up shop in the brain as a brain metastasis. One really interesting thing about this is that the timelines are quite variable. So why is it that some tumors metastasize very early, others not until later? And I'll give an example. This is an example of a fast-growing tumor. So for example, a triple-negative tumor. And here, the breast cancer growth rate might be very fast. So maybe it takes only about a year for a tumor to go from, just starting up to 1 centimeter in size. And maybe it's really fast growing, and it might only take about a month or two for it to double to 2 centimeters. That's a really fast growing tumor. That's typical of triple negative. And it might then be that then you get treated, you have surgery, you have no evidence of cancer on our usual tests, but maybe it grows back fast and you have a metastatic relapse within a year or two. Sometimes you might have a longer period, maybe as long as 5 or 10 years. Usually with this kind of bad breast cancer, triple negative, it tends to come back fast. And we don't know why some might not come back until later. There's this idea of dormancy. Could it be sort of sleeping somewhere and then come back for some reason? When we look at the better behaved cancers, ER positive, HER2 negative, slow growing tumors, it might take years to get to 1 centimeter. It could take 50 years to get to 1 centimeter. It could take another 6 years for it to get to 2 centimeters. And it might take a really long time for it to come back. It might not come back for 20 years. So many mysteries about why that is. We don't know what might make a dormant cell reactivate, what might make it wake up and begin to make trouble and go into the brain and elsewhere. And so we need to answer these questions ultimately to get better at treating and saving patients. This is just an idea from this review article about things maybe we could think about doing to try to make this better. Maybe we could prevent this by early diagnosis and removal, right? So maybe if you can find a cancer really early in stage 1, this never happens because you get to it before this process has started to happen. Maybe we could think of ways of making this cancer cell mature and differentiate into a regular cell. Maybe there are other kinds of targeted therapies, immunotherapies to turn on the immune system, or anti-blood vessel therapies to prevent them from taking over the bloodstream, or things to kind of keep it sleeping in dormancy. There are lots of caveats of reasons why there might be resistance, but I invite you to think about this just as a challenge of how might this work. The other thing that we sometimes think about is there a way to monitor this better or sooner? Standard of care is generally that we just keep doing mammograms after we've finished treating someone in stage 0 through stage 3. We're not always scanning people and things like that because that's a lot of radiation. But people are starting to say, maybe we could take that primary tumor and do genetic sequencing and get some personalized markers, and we could then check in the blood and see if they are being shed in the blood. That might tell us that the cancer was going to come back. So for example, maybe we could check this blood DNA and we could check it at the time of surgery, after surgery and treatment. Maybe it goes down to a really low number, but for some people, maybe what we call this molecular residual disease never really goes away. And that might give us an opportunity to intervene with different medication before it gets high into this recurrence. This is really the frontier right now. We don't do this routinely, but we're getting there. So let's talk about metastatic treatments and outcomes. This again is another busy slide, but I want to make the point that over the last 5 decades, progress has been made. The way this works is here I'm showing you drugs that were developed for the metastatic setting, either initially metastatic at diagnosis in stage 4 or got diagnosed earlier but then recurred elsewhere in the body. And this is early stage, what we call adjuvant or neoadjuvant, so preoperative or postoperative when we're trying to cure the patient. What you'll see is that all these drugs start out in the metastatic setting, and then eventually they get transitioned over to the curative setting. So you see tamoxifen came around in like 1977 for metastatic disease. It got to curative disease in about 1986. And that's mostly about the need. So people who are dying of breast cancer, that's where we try things first because they have the greatest need. But when you look at what's been done, you see, since as we get toward 2020, we see more and more drugs, not so many in the 70s and 90s, but the pace really starts to pick up. We're getting better at science. It's sequencing of the human genome. Lots of other kinds of good science are making it better. We are seeing some that are targeted to ER and PR here. Good examples being all of these, fulvestrant, everolimus, palbociclib, all of those are especially for ER and PR positive. Then there are some that are especially for HER2 positive, TDM1, pertuzumab, all of those are for that. How many are there for triple negative? Gosh, only one, right? So that's another problem with triple negative breast cancer. But you see over here, we have lots of drugs targeted to ER positive, lots to HER2 positive, very little for the triple negative right now. And so when we look at what's happened on a population level over time from 1998 to 2019, you can see what's made a difference in terms of mortality. The biggest one has been early stage treatment contribution to mortality reduction that I showed you earlier. Early stage treatment has been the most important, getting more and more important over time. Screening less and less important as treatment gets better, and metastatic kind of about the same. Not doing a huge amount, but still doing its part in delaying death from breast cancer, even though it's not curative. So just a few words about survival with metastatic disease. How are we doing? The answer is not so great. We're doing our best, but not so great. So if you look at sort of 1998 up to 2020 for HER2 positive breast cancer, this is the triple positive, has all three of the targets, ER, PR, and HER2. We've improved by a median of 2.5 years. So people are living about 4.5 years instead of about 2 years with metastatic disease. That's pretty short for somebody in the prime of life, right? With ER negative, HER2 positive, we've only gotten about 1.5 years better. That's because we don't have that ER to target, right? As we look at HER2 negative breast cancer, this is usually when you have early stage disease, this is the best subtype, ER positive, HER2 negative, but we're not doing so great when they recur. About 2 years up to about 3.5 years over this 20-year period, only an improvement in 1.6 years. But now look at triple negative, right? So unfortunately, survival is still really poor with metastatic disease. It's about 1.2 to 1.5 years, only a budge of 0.4 years over this 20-year period of trying to come up with new drugs. So let's talk a little bit about that. And this is the last section of the talk, and I just want to go over it a bit of confronting this problem. Many would call triple negative breast cancer in some ways a perfect storm. Okay, so this is a really nice review article from a while ago that's still true. And looking at this panel on the right, they're talking about breast cancer specific survival according to subtype. Like I told you, the green here is triple negative, right? They do the worst. They have the worst survival. The orange here is that luminal ER/PR positive, HER2 negative. They do the best. But triple negative breast cancer, like I told you, comes back faster. So here we see the hazard rate for coming back as metastatic disease. Triple negative have a really early bump here. So if it's going to come back, it often comes back fast, as well as being more likely to come back. Non-triple negative have a longer curve, and they aren't as likely to come back. The other problem is triple negative comes to worse sites. So if you look at where it goes, when it metastasizes, 30% to the brain, 40% to the lung, 20% to the liver, all of those things, unfortunately, will kill you quickly. You need those organs to work. Only 10% to bone. We can actually tolerate quite a bit of metastatic disease in the bone. Maybe a person might have some bone pain or possibly a fracture, but usually not. You can live with that for a while. If you look at non-triple negative, look what the most common site is. That one just goes to bone, 40%. You can live a long time with that. fewer going to the visceral vital organs. And also, as I mentioned, fewer molecular targets because we don't have ER, PR, or HER2. So I won't go through all of this, but I'll just mention that there are a lot of novel mechanisms that we're trying to find to seek new targets for this traditionally untargetable disease. This is a cell membrane. This is a cell nucleus. I won't go through all of it, but I'll say that there's a molecule that's been discovered called TROP2 that is more commonly expressed on triple-negative cells, breast cancer cells. There's a new drug. They have terrible names, sacituzumab govitecan. That's a real tongue twister, but it's a very good drug, and we're starting to use that for some triple negative. There's some other drugs like immunotherapy that can turn on the immune system in triple negative breast cancer and get our own immune system to fight it. Those are good. They target something called PD-1, PD-L1. And there's another one called PARP inhibitors that work in the nucleus and help people who have these inherited DNA mutations. So those are all success stories of the last 10 years. And just a brief algorithm for what do you do with these people? Somebody comes in with metastatic triple negative, you're looking for some of these new markers, PD-L1 or BRCA1 and 2. If they have this, maybe you can give them some immunotherapy and chemotherapy. If they don't, you asked if the patient's in a visceral crisis. Does she have bad cancer in the brain or lung or liver that's going to kill her fast? If she does, you're going to give her a lot of different chemotherapy drugs. If not, you can maybe give her only one. If she has one of these genetic mutations, you might go down a path of giving her something there, and then you come to that cool new drug I told you about, sacituzumab. But that's kind of it. Not a lot to do, and we wish we had more. So my final slide here is just for us to think about this as we go ahead. How can we do better with these diseases, particularly for triple negative breast cancer? Early detection is important. Good treatment is important. How can we get it to everybody? More philosophically and broadly, just think about it. What can we do to break the cure barrier for metastatic cancer? That's the holy grail question. So just something to be aware of. And what can we do to mitigate the poor prognosis of metastatic triple negative breast cancer? So that's what I wanted to share with you. I'm going to stop sharing now, if that's all right. And I will be happy to discuss these questions, if that makes sense.
Thank you so much, Dr. Kurian. I can speak for myself. That was incredible. I learned so much. I think it was so detailed and covered sort of all the contours of knowledge. It's a very complex condition. So many stages, so many different things going on. I think we learned so much from your very detailed presentation.
Okay.
And if it's okay, I have a few questions.
Hey.
I was really intrigued by your slide. I think it was 25, which about tracking tumor DNA using personalized primers.
Yeah.
In my day job, I'm a researcher at Stanford Genome Technology Center, and we study rare conditions often caused by regulatory disruptions, and we develop custom primer. But we also look at other types of data, multi-omics data, metabolomics, proteomics, other clinical data, and in an effort to understand sort of systemic disruptions. And I was really curious to the extent to which multi-omics data sets informs your research, and more broadly the challenges that you face in breast cancer data itself.
So it's such a good question, and I love it that that's your background. I'd love to talk to you another time. I think you must know so much about this, and it's really fascinating. So I think, we always want big data and more data. Of course we do. That's going to be helpful, I think. The challenge is always getting that at a large scale. So in a large number of patients, if you want to sort of study a lot of people, usually we have only what is collected routinely as a part of routine care, just because some people go on trials. Actually, only 3% of adults in America are treated on clinical trials for cancer, which is shameful. I mean, we all feel that it's shameful. It should be much higher, but it's only 3%. And so the other 97% of cancer patients in America are getting routine care. And so if you want big data, usually you have to look at what was routinely measured. Unfortunately, we don't routinely do metabolomics. I wish we did, right? But so I think we often don't have that at scale. I've been very interested in the genetics that we can get at scale, and I've actually done some work linking genetic testing, germline genetic testing to cancer risk to population-based cancer registries, including the statewide California Cancer Registry that covers 39 million people in our state. So we've learned a lot from that. That's been very exciting, and we're doing more to understand causes of cancer in those people and also understanding how that relates to people's survival and treatment. So I think that's great. We always want bigger data. Sometimes we're limited by what's actually done in clinical practice.
Do you sort of have a very, what is your data sort of cleaning pipeline? Do you have, very complex, who do you work with? How does that pipeline come about?
I always say, and this is true, I'm just a doctor, and I'm so lucky to get to work with wonderful people who know what they're doing, like you, like your colleagues, who are wonderful data scientists and analysts and know how to manage the data in a much better way. So I've had the privilege of working with lots of people at Stanford who are, again, data scientists and analysts and have really done exciting things and exploring things we can do. So I've worked with Daniel Rubin in bioinformatics and his colleagues, Sylvia Plavritis and her colleagues, Tina Hernandez-Bissard, some people there who are all wonderful and have been exploring strategies for certainly ensuring the quality of the data, but also for doing new kinds of approaches. So different kinds of modeling, neural network modeling. Some of these things are a bit over my head, again, as a doctor, but data scientists find really great things to do with these data, and I'm learning too. I've also collaborated a lot with the team at the University of Michigan, with whom I've been doing this large germline genetic study. We have collaborators also at USC and Emory and UCSF for that one. So I've been really fortunate to learn from people all over.
That's wonderful. Could you just speak to a little bit about, you mentioned some of your colleagues doing statistical methodologies. What sort of recent statistical methodologies have you found particularly useful? Because, in our datathon, we're sort of really focused on machine learning. And so it would be really interesting to hear from you what you found useful in your research.
Great. Yeah. So I will say, one question might be, how do we know what we know about breast cancer or about cancer at all? And so the standard of care in the field actually is those clinical trials. So, it's pretty lame that we can't get more than 3% on them. And I'm not blaming the patients. I'm blaming, the system. So it's a challenge, and America needs to do better with that in a number of ways. But the way we decide, how do we decide if we can treat a patient with the drug? The standard of care is to do a randomized clinical trial. So you have two patients, patient agrees to be on a trial. One patient gets the standard of care, whatever it is. The other patient gets something that we have reason to think may be better than the standard of care. If we know it's better, we're not allowed to do a trial because that's unethical. So we have to be in what we call equipoise, where we can only give it if we think it might be better. And so we follow patients, a lot of them for a long time. Ultimately, we get an answer, and that's how drugs get approved in this country and others as well. So that's the standard of care. However, remember, there's still 97% of patients who are not treated on clinical trials. How do we learn from them? So it's exactly what you're asking. I think that there's tremendously rich opportunity here for machine learning, for AI approaches, for neural network approaches, for all of these things that, again, I'm really an admirer and a learner of those things, right? And I think it's the data scientists who are taking that forward. So I think it's open season, and I would love to see what anyone wants to do with that. I think we'll learn a lot from it. I think one question will always be making sure that we can interpret what is found with such methods in a way that makes sense. And so I think that will be, do we understand what this is showing? Is it plausible? Does it align with things that we understand from clinical trials or from other kinds of studies? So that fact-checking and benchmarking will always be important.
Thank you so much. I have a final question related to your own personal journey as a leading researcher in this field. Our audience comprises beginner and intermediate data scientists from around the world, and many of them are at the beginning stages of their career.
Right.
And we'd love to hear from you. What challenges did you face in your career, and how did you overcome them? What advice do you have for a beginning researcher?
Yeah, so I feel, it's interesting. I feel lucky every day to do what I do. So I'm 50. I just turned 50, and I'm having more fun than I've ever had in this field, which is unusual, right? I think, maybe not for, I don't think it's unusual for science, but for life in general, not everybody is so excited about their work at midlife. So I'm incredibly blessed to have that opportunity, and it's thrilling. So I'm so glad that there are people here who are pursuing really lifelong learning, right? And just sort of thinking and learning and doing new problems. That's how you stay excited and attached to life. And so I think, for me, I have been compelled by the problem of cancer. I think it is obviously just a huge scourge in our society, right? I've had friends and family who've suffered from this and succumbed to this. And so I see it, it's something that always felt like a fight that was worth my career, worth spending my career on. And so that was where that went. I have always had this sort of odd, I don't know why, but I have an epidemiologic view of the world. So I tend to think from a bird's eye view and sort of think about looking at everybody, not just a few people, but everybody, who gets sick and who doesn't. And once people get sick, who gets well and who doesn't, right? And I think that gets into both big questions of what's causing disease and what's causing recovery, but also questions of who is privileged enough to be treated well and who isn't, right? So there are many overtones there. And so that sort of led me to epidemiology and thinking about risk and thinking about, cause and stuff like that. So it's sort of a meandering path, but I primarily am a doctor. That's how I identify. I went to medical school I went to Stanford undergrad, and then I went to medical school at Harvard, and then I did residency in internal medicine at Mass General. And I came back to Stanford, which made me very happy to specialize in oncology and to do a master's degree in epidemiology. So that was my training. And I just sort of kept being drawn to questions that were based on my practice. And that's always been the inspiration, is I continue to see patients 2 days a week. I treat breast cancer, and I also do cancer genetic risk assessment. And the questions are what comes up. So when you see the kind of things I was showing you of people, dying young of breast cancer, these are compelling, these push you forward. And so I think figuring out what to study hasn't been the problem, because one is driven by impact. And so I would say for young people or for people entering the field, I would think hard about whatever you're going to study. What do you want to sort of, what kind of an impact do you want to make? And I think if it's in health, it's usually knowing the clinical setting. And that could be talking to clinicians, nurses, doctors who face patients. It's always good to talk to patients, first of all, right? So patient advocates and other patients, and really spending time with those people who can help define the problems. And then you as a data scientist can help solve them. So that would be what I would be thinking about.
That's incredibly wise, and we benefit from your experience.
Oh, I benefit from yours. So
no, I think this problem is so difficult, and it needs concerted focus and determination.
That's right.
And I think this field is so fortunate to have that commitment from you for so many years.
You're very kind. I think people who go into it, most oncologists are called, I would say most people in medicine, a lot of people hate oncology because they think it's depressing. Those of us who go in, I think, are pulled and wouldn't be anywhere else for whatever reason. Sometimes it's just personality. Sometimes it's a personal experience of family members, something like that. But usually people are in the fight for the long term, basically. But based on what we've seen of patients, you don't really walk away.
Yeah, and it's a compelling fight. I mean, it needs a lot of determination, a lot of fight.
It's a privilege.
It's
a privilege.
So we're grateful for your contributions, and we're grateful for you for that you joined us today.
Oh, my pleasure.
Our recording.
Thank you so much.
And I'm sure that our audience has learned so much. I've learned so much tremendously from your presentation and your chat. Thank you so much.
Thank you. I really appreciate your having me. It's a privilege to contribute in any way. I think you're doing great things with this group.
Thank you.